you. The following case is going to be about a patient from the cardio-oncology clinic in Rabin Medical Center. Amazing patient, if I might add to the protocol, just that. 43 years old patient was diagnosed with infiltrating ductal carcinoma of the left breast in 2013. She had mastectomy of her left breast and axillary lymph node dissection, and then a reconstruction surgery with a silicone implant. She was treated in another hospital, and she got adriamycin and cytoxan 6 treatments and chest radiotherapy. She had no known cardiac risk factors and no comorbidities. Echocardiography prior to chemotherapy showed a good function of both ventricles, estimated ejection fraction of 60%, and normal valves. During chemotherapy, she had another echocardiography exam that was with low quality images, but still it was estimated good LV and good RV function. They didn't do a Simpson equation, so we don't have the EF. Last chemotherapy was in April, and then she had chronic treatment with tamoxifen. In July, 3 months post-chemotherapy, and during radiation therapy, she complains on effort dyspnea. She's orthopneic, complains of PND, and says that her left leg is painful. She denies chest pain. Her family physician hears her complaints and sends her to echocardiography exam. Just a moment. Okay, you can see parasternal long axis loop from her echocardiography exam, and very severe LV dysfunction, estimated EF around 15%. She had moderate mitral regurgitation, severe tricuspid regurgitation, diastolic dysfunction with restrictive filling pattern. Not so good. Then she was referred by her doctor to another hospital for a further evaluation. There, she was found dyspneic, borderline blood pressure, a little bit tachycardic, and with oxygen saturation 92% room air. On her physical examination, no peripheral edema, normal lung auscultation, and they didn't mention JVP, so we don't know. They did a chest X-ray that was normal, and they thought about ruling out pulmonary embolism, so a CT angiography was done and was negative for PE, but showed, of course, pulmonary congestion signs. She was treated with beta blockers, ACE inhibitors, and furosemide, and discharged with a diagnosis of heart failure unspecified. She was referred to a technetium sestamibi stress test in August, 2 weeks later, with no signs of ischemia. At rest, it showed severe LV dysfunction without regional wall motion abnormality that was consistent with non-ischemic cardiomyopathy. Her oncologist then referred her to the cardio-oncology clinic due to suspected anthracycline cardiomyopathy. She was still dyspneic, so heart failure treatment was optimized, and aldactone and digoxin were added to her regular treatment. Then she reported she's feeling better. Troponin levels were taken in 2 separate occasions and were negative in both times. On follow-up, a serial echocardiography, first one in October, still showed severe LV dysfunction. EF estimation was a little bit higher, 20%. The diastolic function is now pseudo-normal filling pattern. That's grade 2 diastolic dysfunction, so it's a little bit improved, and only mild to moderate mitral regurgitation and tricuspid regurgitation. Then in January 2015, she's sent to a stress echocardiography to check for contractile response. It was subnormal, but the LV function was a little bit better, moderate to severe LV dysfunction. EF estimated around 30 to 35%, only grade 1 diastolic dysfunction, and normal valves. Okay, this is an MRI, cardiac MRI picture that she has done also in January 2015. Okay, we can see the breast implant over here. That's a two-chamber view of the heart. A better function. The EF was estimated around 35% to a little bit more. We also can see the thinned myocardium. Okay. Okay. Enhanced gadolinium was minimal, only in the insertion points here. Or that's okay. Enhancement with gadolinium was minimal, only in the insertion points of the RV ventricle to the septum over here. You can see it here. Oh, that's okay. Okay. Hinge points. Oh, it's okay. It's okay. Okay. So we see it in the hinge points here in the right ventricle. It's the thinning of the myocardium and the minimal scar are consistent with anthracycline cardiomyopathy in this MRI. So we know that the role of anthracycline is well established in treatment of breast cancer, but often the benefit is limited by the risk of myocardial damage, and that's the main issue here. The anthracycline cardiotoxicity is usually non-reversible damage, type 1 cardiotoxicity, that involves cell damage and apoptosis and progressive cardiovascular disease, non-reversible. The type 2 reversible dysfunction is really it's uncommon. If we talk about risk factors, then cumulative dose, age, extremities of age, both the young and the old, concomitant administration of other cardiotoxic agents, concurrent or pure chest radiation that we know that our patient got concurrent radiation, and pre-existing cardiovascular disease. So some points for me or for you to think about. What about the use of dexamethasone in the treatment of this patient? I don't know the dose that she got, the exact dose, because she was treated in another hospital, but something to think about. Did she have any genetic predisposition for anthracycline cardiotoxicity? She had minimal risk factors for toxicity, and she had severe LV dysfunction post-treatment. And what about earlier treatment or preventive treatment with beta blockers and angiotensin converting enzyme? We still don't have the answer. There's the PRADA trial that is ongoing, but I didn't see any results. And the role of cardiac MRI, I think it's very important because it can give us mainly the opportunity to rule other things for the differential diagnosis. Thank you.